Welcome to the deep dive. You asked for a focused revision session on multiple endocrine neoplasia, or MN, so here we are.
Yep. Ready to tackle it.
It's this interesting group of rare genetic conditions. Basically, tumors start popping up in multiple endocrine glands, sort of a chain reaction in the hormone system.
Exactly. And it's not just one type of reaction. We're mainly looking at four kinds: MEN1, MEN2A, MEN2B, and then the really rare MEN4.
Four types, okay.
And the key thing, especially for revision, is that each one has a different genetic cause and shows up in its own distinct way, different patterns.
Right. So our mission today is pretty clear. Pull out the essential high-yield info on MN you absolutely need to know. We'll cover everything from the basics right through to complications.
And we'll try to drop in some memory aids along the way because, let's face it, these things can get complicated and little tricks help.
Definitely. Okay, let's start at square one. What is MN in simple terms?
Okay, so at its heart, MN is basically a set of rare genetic disorders. The main thing is they cause tumors, growths in multiple endocrine glands.
Not just one gland acting up on its own.
No, exactly. It's a pattern across several hormone-producing spots. And remember those four types: MEN1, MEN2A, MEN2B, MEN4. Keep them separate in your head.
Got it. So what actually triggers this? Is it just bad luck, or is there something specific causing it?
Oh, it's definitely specific. It's primarily caused by inherited genetic mutations. These are usually passed down in families.
Inherited, okay.
Yeah. And for each type, there's a specific gene that's usually involved. For MEN1, it's the MEN1 gene. Easy enough, right?
Huh, yeah, that one's straightforward.
For MEN2A and MEN2B, the culprit is the RET gene, specifically the RET proto-oncogene that's on chromosome 10.
Proto-oncogene, that sounds important.
It is. Normally, it helps control cell growth.
Yeah.
But when it mutates, it can become an oncogene, sort of like hitting the accelerator on cell growth, potentially leading to tumors.
Right, uncontrolled growth.
Exactly.
Yeah.
And then for MEN4, which is much rarer, it's linked to the CDKN1B gene.
Okay. And how are these passed down?
Good question. It's usually an autosomal dominant pattern, which basically means, you only need to inherit one copy of the mutated gene from one parent to have a high chance of developing the condition.
Just one copy is enough. Wow. So if your family has a history.
That's the biggest risk factor, hands down. A strong family history of men means your risk of carrying that specific mutation and potentially developing the condition is way higher.
Makes sense. So that specific mutation is the key risk factor.
Precisely.
Okay, we've covered the what and the why. How does it actually work? How do these mutations lead to tumors in all these different glands?
So the pathophysiology, the how, boils down to abnormal growth of endocrine tissue. These mutations basically mess up the normal signals that tell cells when to grow, when to stop. They kind of take the brakes off.
Leading to tumors.
Right. And the glands that get hit most often are the parathyroids. They handle calcium, the gastroenteropancreatic tract, so stomach and pancreas hormones.
Like insulin and gastrin.
Yep. Also the anterior pituitary, the thyroid, specifically the C cells making calcitonin, and the adrenal glands, especially the inner part, the medulla.
That's quite a range of glands. So if someone shows up with tumors in a few of these places, how do you tell if it's MN or maybe something else entirely? What are the lookalikes?
That's the differential diagnosis challenge.
Yeah.
Yeah, other conditions can look similar, like familial non-medullary thyroid cancer, if the thyroid's involved,
Right.
or pheochromocytoma paraganglioma syndromes. It's mainly adrenal-type tumors. Those can also be genetic, but are different from men.
So it's not always men.
No, and sometimes people just develop unrelated, sort of sporadic endocrine tumors in different glands by chance. The key to figuring it out is often the specific combination of glands, the age it starts, family history, and crucially genetic testing results.
Genetic testing seems key then. How common are these MEN syndromes overall? Are we talking super rare?
They are definitely rare. MEN1 is estimated around 1 in 30,000 people. MEN2A is similar, maybe 1 in 35,000.
Okay, still quite rare.
Very. And MEN2B is much rarer still, like 1 in a million. MEN4 is extremely rare. We barely have numbers for it.
Wow.
And, these numbers might even be underestimates. Someone might first show up with just one tumor, and it takes time to realize it's part of a wider MEN picture.
Right, the diagnosis might lag.
Exactly. For MEN1 specifically, it's got high penetrance, meaning if you have the gene, you're very likely to get the condition. And it affects men and women equally.
And the gene location.
Ah, yes. MEN1 gene is on chromosome 11 at Q13. And interestingly, about 10% of MNN1 cases aren't inherited. They're de novo mutations, just appearing spontaneously.
Okay, good to know. So moving on to the clinical side, what signs or symptoms might actually make someone think, could this be men?
Well, it's really diverse because it depends so much on the specific N type and which glands are overactive or developing tumors.
Makes sense.
But some general flags might be things like hyperparathyroidism, high calcium issues, pituitary tumors causing hormone problems, or maybe pressure symptoms like headaches, vision
The
changes.
mass effect you mentioned.
Right. Then there's medullary thyroid carcinoma, MTC, that's specific thyroid cancer. Pheochromocytoma, giving those episodes of high blood pressure, sweating, racing heart.
Scary stuff.
Yeah. Other adrenal tumors, pancreatic neuroendocrine tumors.
Mhm.
You can also see skin lesions sometimes, or even skeletal issues. And of course, that family history is a big clue.
When does this usually start?
Often the underlying process begins in the teenage years, but the actual diagnosis might not happen until the 30s or 40s, sometimes later.
So it can take a while to spot.
It can. And interestingly, some skin changes, like angiofibromas, collagenomas, lipomas, can show up in the teens. Sometimes even before the endocrine problems become obvious, they can be early markers.
Little clues on the skin. And these hormone issues, they cause specific problems, right? Like syndromes.
Absolutely. When the tumors overproduce hormones, you get distinct syndromes. Hyperparathyroidism causes the high calcium symptoms. Gastrinomas lead to Zollinger-Ellison syndrome, really bad stomach ulcers. Insulinomas cause hypoglycemia, low blood sugar. Pituitary tumors might cause missed periods, amenorrhea, or acromegaly if it's growth hormone.
So lots of potential downstream effects.
Definitely. And those skin lesions, while usually benign, were super helpful visual clues for diagnosis. There are also some less common links being explored, like with carcinoid tumors, but that's still a bit controversial.
Okay, let's dive into the specifics. MEN1. I think I remember a mnemonic for this one.
Ah, yes, the classic 3 Ps for MEN1. It's a great memory aid, stands for parathyroid, pituitary, and pancreas.
The 3 Ps. Got it. Tell me about the parathyroid part.
Okay, parathyroid is the most common feature. It affects about 95% of MEN1 patients. Usually presents as hyperparathyroidism. Sometimes it's picked up on routine blood tests, asymptomatic hypercalcemia, or it presents with classic high calcium symptoms.
And it affects all the glands.
Often, yes. It tends to be diffuse hyperplasia, meaning all 4 glands get bigger, though distinct tumors, adenomas, can form too.
Okay, P number 1, parathyroid. What about pancreas?
Right? The second P tumors in the gastroenteropancreatic system happen in quite a few patients, maybe 30 to 80%. If they're not caught by screening, they typically show up between ages 15 and 50.
What kind of pancreatic tumors?
The most common are gastrinomas, over 60%, causing that Zollinger-Ellison syndrome. Peptic ulcers are a really significant issue there, can be quite severe.
Yeah, you mentioned that.
Then about 30% are insulinomas, causing low blood sugar. You can also get rarer ones like viipormas or glucogenomas. And again, diffuse pancreatic changes, hyperplasia, are often seen.
Okay. And the final P, pituitary.
Yep, anterior pituitary tumors, also very common, found in maybe 30% on screening, but seen in up to half of patients post-mortem.
Higher than you might think then.
Definitely.
Hmm.
Unlike the others, you don't really see diffuse hyperplasia here. The most common type is a prolactinoma, secreting prolactin, making up about 30%. They can sometimes be a bit more aggressive than sporadic ones.
Okay.
Acromegaly from growth hormone tumors is also seen in about 30%. Other functioning pituitary tumors are pretty rare in MEN1.
And don't forget the skin stuff.
Right. Good reminder. Those angiofibromas, collagenomas, lipomas, benign but useful markers, especially early on.
Okay, 3 Ps for MEN1 locked in. Now, MEN2. It's got subtypes, right?
Yes, MEN2 is split into MEN2A and MEN2B. The general symptoms often relate to medullary thyroid carcinoma, MTC, hyperparathyroidism, or pheochromocytoma.
MTC. That's the thyroid cancer.
That specific type, yes. And a key point for MEN2 is that MTC can start really early, sometimes even in infancy, like 2 months old.
Wow, that young.
Yeah. So symptoms might be things like high blood pressure, sweating episodes, diarrhea, maybe itchy skin, or just a neck lump. If hyperparathyroidism is involved, you get the high calcium symptoms, constipation, peeing a lot, confusion.
Right.
And pheochromocytoma, that adrenal tumor, develops in around 40% of MEN2 patients overall.
Okay, so how do 2A and 2B differ? Are there mnemonics for these two?
There are. For MEN2A, which is sometimes called Sippel syndrome, it's like 2 Ps plus MTC.
UPS plus MTC.
Yep. parathyroid and pheochromocytoma, plus the medullary thyroid carcinoma, which happens in almost everyone with MEN2A, nearly 100%. It's often the first thing noticed.
Okay.
Pheochromocytoma occurs in maybe 30–50%, and hyperparathyroidism in about 20%. Some people might also develop kidney stones or kidney damage because of the calcium issues.
Okay, 2PS plus MTC for MEN2A. What about MEN2B?
For MEN2B, think 1P plus MTC, but with some really distinct physical features added in.
1P, which one?
Pheochromocytoma, so it's pheo plus MTC, plus things like a Marfanoid habitus, that tall, slender build with long limbs.
Ah, like Marfan syndrome features.
Sort of, yeah. Plus mucosal neuromas, these little benign nerve bumps often seen on the lips, tongue, eyelids, and other skeletal abnormalities.
So quite a distinct look.
Very distinct. The MTC in MEN2B tends to start earlier and be more aggressive than in 2A. Pheos occur in about 50%, often multiple, and in both adrenals. And overall, MEN2B often presents earlier than 2A.
Any other features for 2B?
Yes, intestinal ganglion neuromatosis is common, affecting gut nerves in about 75%. And delayed puberty can also be a feature.
Okay, quite different pictures then. So we know the features. How do doctors actually investigate these? What tests are involved?
Generally, it's a mix. You need genetic testing, that's fundamental, to find the specific mutation. Then imaging, CT, MRI, ultrasound to actually see the tumors, and blood tests to check hormone levels and specific tumor markers.
Let's break that down. MEN1 investigations.
For MEN1, screening relatives is really important, first and second degree. Diagnosis often starts with clinical suspicion. Those skin signs, high calcium, maybe stomach acid issues.
Right.
Blood tests confirm hormone overproduction. Imaging locates tumors. But the definitive diagnosis really comes down to DNA testing for that MEN1 gene mutation.
DNA testing is key.
Absolutely. Prenatal diagnosis is also possible in families with known MEN1. When screening relatives, you're looking for early signs of the parathyroid, pancreas, or pituitary.
Makes sense.
And you might also consider MEN1 testing if someone just shows up with, say, a gastronoma or insulinoma out of the blue, even without a family history. Routine testing is generally recommended for classic MEN1 familial hyperparathyroidism or sporadic hyperparathyroidism, plus another MEN1 tumor.
Is the genetic testing accurate?
Very. Genetic linkage analysis can be over 95% predictive in known families.
Okay. What about investigations for MEN2?
For MEN10, screening for pheochromocytoma is vital. That usually involves 24-hour urine tests for catecholamines and VMA. Imaging like abdominal MRI or MEG scans helps find them.
And for the thyroid part, MTC.
High plasma calcitonin is the big marker for MTC. If thyroid nodules are found on exam or imaging, you'd use ultrasound and fine needle aspiration biopsy.
Okay. Parathyroid?
Check serum calcium, parathyroid hormone, PTH, and maybe the urine calcium creatinine ratio.
And the genetics.
Molecular diagnosis looks for mutations in that RET proto-oncogene. Again, testing is highly predictive, like 98–99% accurate.
Wow. So how often do people get screened?
For people at risk, it's usually annual screening starting around age 10. That involves urine catecholamines, serum calcium, and PTH.
And after treatment for MTC?
You monitor for recurrence using plasma calcitonin, CEA levels, and sometimes provocative calcitonin tests.
Right. So once you have a diagnosis, what's the plan? How is MN managed?
It absolutely needs a multidisciplinary team. You need endocrinologists, geneticists, surgeons, maybe others, depending on the specific problems.
Team effort.
Totally. Treatment involves things like surgery to remove tumors, hormone replacement if needed, sometimes targeted medications, and always regular monitoring. Genetic counseling for the patient and family is also essential.
Let's focus on MEN1 management.
Okay. Genetic counseling is step one. Medically, you might use drugs like diazoxide for insulomas, PBIs for gastronomas, or hormone replacement. Skin tumors can be surgically removed.
What about the internal tumors?
Surgery is often needed for parathyroid, pancreatic, or pituitary tumors, but the specific approach really varies based on the tumor size, location, and whether it's making hormones.
Okay. And MEN2 management.
Key goals are identifying the RET mutation and reducing the risks, especially from MTC and pheo. Surgery is usually needed for pheochromocytomas, or the precursor, adrenal medullary hyperplasia.
And the thyroid.
Total thyroidectomy is generally recommended for MEN2A to prevent or treat MTC. For MEN2B, because the MTC is often more aggressive, surgery is even more critical, thyroidectomy plus lymph node dissection, along with close monitoring of tumor markers.
Any special considerations?
Yeah, anesthesia can be tricky if someone has a pheochromocytoma. need careful management. And prophylactic thyroidectomy, removing the thyroid before cancer develops, is often advised for people with high-risk RET mutations found through genetic testing.
Proactive surgery.
Exactly. And follow-up involves monitoring those calcitonin and CEA levels for MTC recurrence.
So, looking at the big picture, what's the prognosis? What's the outlook for someone with MEN?
It really varies. Depends heavily on the MEN type, how advanced the tumors are when found, and how well treatment works. But regular monitoring, early detection, good management, they definitely improve outcomes and quality of life.
Are there differences between the types?
Yes. For MEN1, life expectancy can be lower than average, often due to malignant pancreatic tumors, especially gastrinomas.
And MEN2.
MEN2B generally has a worse prognosis than MEN2A, mainly because of that aggressive MTC. If MTC is already clinically apparent at diagnosis in MEN2B, the outlook can be poor, sadly, with metastatic disease being a common cause of death, sometimes even in the mid-20s.
That's tough. What about complications generally?
Well, you can get complications directly from the tumors, like the effects of high calcium from hyperparathyroidism, serious heart issues from pheochromocytomas or MTC spreading.
Makes sense.
Then there are potential surgical complications, like with any operation. And even with treatment, managing long-term hormone imbalances can sometimes lead to other health problems down the line.
Okay, this has been incredibly comprehensive. If we had to boil it down, what are the absolute must-know takeaways about MEN for revision?
Right, key points. MN syndromes are rare, genetic disorders, autosomal dominant inheritance usual. They cause tumors in multiple endocrine glands.
Multiple is the key word.
Absolutely. And the patterns differ by type. MEN1, think 3Ps, parathyroid, pituitary, pancreas. MEN2A, 2PS, parathyroid, pheo, plus MTC. MEN2B, 1P, pheo, plus MTC, plus those distinct features, marthenoid neuromas. And the rare MEN4.
Got the mnemonics?
Each type linked to specific genes, MEN1 or ET, CDKN1B.
Yeah.
Early detection via screening and genetic testing, plus tailored multidisciplinary management are absolutely critical.
Fantastic summary. Okay, final thought then. Given how complex MEN is, how varied it can be, what do you think are the most crucial steps to make sure people actually get diagnosed in time and get the right care, especially families at risk?
That's a great question. I think fundamentally it's about awareness among doctors remembering to even consider MEN when seeing patients with multiple endocrine issues or that strong family history.
Keeping it on the radar.
Exactly. That needs to go hand in hand with good access to genetic testing and proper counseling. And then being proactive about screening at-risk family members. That early detection can make a huge difference.
Awareness, access, and screening. Crucial points indeed. Well, for everyone listening and revising, don't forget PassTheMSRA.com and FreeMSRA.com. Loads of great resources there.
Definitely check them out.
Thanks so much for walking us through this complex topic today, and thanks to all of you for joining us on the deep dive. We'll catch you next time.